Welcome to the First Fill. I'm Katie Meyer, VP of Education at APHA. In this episode, we will be reviewing the American College of Cardiology, American Heart Association clinical practice guidelines for the prevention, detection, evaluation, and management of high blood pressure in adults. These guidelines are hot off the press as of last month and will key in on what changes are most important for pharmacists to be aware of. Before we dive in, let me introduce our guests today, our APHA fellows, Caitlin and Aya. Caitlin and Aya, please introduce yourselves.
Hi, my name is Caitlin Valentino. I am this year's Education Fellow with APHA and recently graduated from Temple University.
Hi, my name is Ayo Adefioye. I graduated from Cedarville University in 2023, and I am this year's new Advanced Education Fellow.
Thanks so much, Caitlin and Aya. All right, let's dive in because boy, oh boy, do we have a lot to cover today. So let me start with Aya. Aya, what are the most significant changes in the 2025 hypertension guideline compared to the 2017 guidelines?
Yeah, so in the 2025 guideline updates, blood pressure categories remain unchanged. Normal, elevated, stage 1 and stage 2 hypertension remain the same as 2017 guideline. What's new is the shift towards risk-based management. Rather than reacting solely to the blood pressure number, clinicians now consider the patient's overall cardiovascular risk over time. There is a terminology change, with hypertensive urgency now called severe hypertension. Patients with a blood pressure of greater than 180 over 120 should be evaluated and treated in outpatient settings. Another addition in the 2025 guidelines is the Prevent Risk Calculator. The calculator helps clinicians estimate both 10-year and 30-year cardiovascular risk, not just ASCVD events. The Prevent calculator is applicable to adults aged 30 to 79 compared with the older pooled cohort equation of adults aged 40 to 79. The calculator uses factors such as age, sex, blood pressure, cholesterol, diabetes, smoking status, BMI, and others to guide treatment decisions. It helps clinicians identify high-risk patients, including younger adults who may have mild blood pressure elevation but higher lifetime cardiovascular risk. The Prevent score guides medication decisions mainly for stage 1 hypertension. For stage 2, medication is generally recommended regardless of the risk score. Clinicians are encouraged to consider lifetime cardiovascular risk when deciding on antihypertensive therapy, especially in stage 1 patients. Other highlights of the guidelines include an increased emphasis on home blood pressure monitoring and standardized measurement to improve accuracy. The guideline also expands recommendations for special populations, including patients with CKD, pregnancy, older adults, and obesity. Also, it increases attention to health disparities and social determinants of health.
Thank you, Aya. Sounds like like I said earlier, there's a lot for us to jam pack into this update here. Now, how have definitions, classifications, and treatment thresholds evolved, and what does that mean for diagnosis, intervention, and detection of high blood pressure?
Well, as I said a little earlier, the definitions and classifications of hypertension remain the same. So, normal, less than 120 over less than 80. Elevated is 120 to 129 over less than 80. Stage 1 is 130 to 139 over 80 to 89. And stage 2 is greater than or equal to 140 over greater than or equal to 90. Treatment decisions now focus on risk, not just blood pressure numbers. For stage 1 hypertension, medication is recommended if the 10-year cardiovascular risk from the Prevent calculator is greater than or equal to 7.5%. If the patient's risk is less than 7.5%, lifestyle modifications remain first line. For stage 2 hypertension, medication is generally recommended regardless of calculated risk. This approach reflects personalized, risk-based care rather than just a one-size-fits-all approach. Out-of-office monitoring, such as home and ambulatory blood pressure checks, is emphasized for accurate diagnosis and follow-up. This helps avoid any misclassification from white coat or masked hypertension. To pull it all together, the 2025 guideline keeps the familiar blood pressure categories, but changes how clinicians diagnose and treat patients. The big shift is towards risk based management, with the Prevent calculator helping clinicians patient centered decisions based on 10 and 30-year cardiovascular risk. For stage one, medication is considered if the 10-year prevent risk is 7.5% or higher. Lifestyle changes remain first line for lower risk patients. Greater focus on home and out of office blood pressure monitoring, attention to special populations, and social determinants of health. Bottom line, it's not just about the numbers anymore, it's about personalized and patient centered care.
Thank you, Io, for that great review. All right, Caitlin, you're up now. So, what recommendations were added to the guidelines regarding special populations like pregnant patients and patients with CKD?
Certainly. So the guideline introduces a more stringent approach with specific recommendations for managing hypertension in pregnancy to reduce maternal and fetal risks. For pregnant individuals with chronic hypertension, defined as having hypertension prior to pregnancy or before 20 weeks gestation, treatment should be initiated if the systolic blood pressure is greater than or equal to 140, or diastolic blood pressure is greater than or equal to 90, with a goal to have blood pressure readings lower than 140 over 90. For individuals with hypertension who are planning to become pregnant, labetalol and extended release nifedipine are the preferred agents to treat hypertension and minimize fetal risk. These patients should also be counseled on the benefits of low-dose aspirin and taking one 81 milligram tablet to reduce the risk of preeclampsia beginning after 12 weeks gestation. Other common oral antihypertensives recommended for use in pregnancy include methyldopa and hydrochlorothiazide. Pregnant individuals with systolic blood pressure greater than or equal to 160 or diastolic blood pressure greater than or equal to 110 on repeat measurements within 15 minutes should receive antihypertensive medication to lower the blood pressure to lower than 160 over 110 within 30 to 60 minutes to prevent the adverse effects. Here you should be using preferred agents, labetalol or extended release nifedipine. The guideline also sets goals for hypertension in patients with CKD, or chronic kidney disease. For adults with hypertension and chronic kidney disease defined as less than 60 or albuminuria greater than or equal to 30, treatment should target a goal of systolic blood pressure less than 130 to decrease all-cause mortality. In these patients, RAAS inhibitors, either with an ACE inhibitor or an ARB, are recommended to decrease cardiovascular disease and delay progression of kidney disease. The guidelines do specifically state that these recommendations do not apply to your dialysis patients due to limited data in patients receiving chronic hemo or peritoneal dialysis. They also state that there is insufficient evidence to support specific recommendations on blood pressure targets or agents for patients who have received a kidney transplant. Blood pressure goals and treatment mechanisms should be individualized for your older adults, including frail and institutionalized individuals based on predicted lifespan, frailty, risk of orthostatic hypertension, and patient goals of care. In patients with many or multiple social determinants of health that affect adherence to antihypertensive medications, the guidelines highlight the importance of multidisciplinary teams to help with medication access and assess for other structural barriers to optimize patient-centered care.
Awesome. Thanks, Caitlin. With these updates, clinicians can really empower individuals to take control of their own health. On that note, how does the guideline address technology and innovation in blood pressure monitoring, and what are the practical takeaways for clinicians and their patients?
Great question. The 2025 hypertension guideline takes a clear stance on the role of technology in blood pressure monitoring. It places an emphasis on accuracy, accessibility, and integration into care while warning against reliance on unvalidated devices. Some of the major points include home blood pressure monitoring is strongly recommended for confirming the diagnosis of hypertension, monitoring treatment response, and supporting medication titration and lifestyle changes. There is an emphasis on following standard protocols and using validated devices with appropriate cuff size. Pharmacists can educate patients on proper technique and encourage regular home blood pressure monitoring, especially for those with stage 1 hypertension or suspected white coat hypertension. Cuffless devices like smartwatches are not recommended for diagnosis or management of hypertension. The guideline highlights concerns of accuracy, validation, and reliability. Pharmacists should advise patients to avoid relying solely on cuffless devices until further validation is available, and the use of FDA-cleared, validated cuff-based monitors should be encouraged. Emerging evidence supports combining home blood pressure monitoring with telehealth counseling, medication titration algorithms, and patient education platforms support patient adherence and greater blood pressure reductions. To support their patients, pharmacists can direct patients to validated device lists, provide clear instructions on how and when to measure blood pressure at home, use electronic health record integrated platforms to track home blood pressure data and guide treatment, and avoid over-reliance on consumer wearables for clinical decision-making. Pharmacists can combine technology with human touch through education, follow-up, and shared decision-making.
Great. Thank you, Caitlin and Io, for such an insightful overview of the key updates to the 2025 hypertension guidelines. That was a great foundation for understanding what is new and why it matters. To summarize, relevant updates for pharmacists related to the updated hypertension guidelines include inclusion of a new calculator called the Prevent Calculator, which helps clinicians identify high-risk patients, including younger adults who may have mild blood pressure elevation but a high lifetime cardiovascular risk. While definitions and staging criteria remain the same, individuals with stage 1 hypertension and a 10-year cardiovascular risk based on the Prevent Calculator of or equal to 7.5% to consider pharmacotherapy. More stringent guidelines for treatment of hypertension in individuals who are pregnant or planning to become pregnant were also included, with treatment recommendations if systolic blood pressure is greater than or equal to 140 or diastolic pressure is greater than or equal to 90, with a goal to have blood pressure readings lower than 140 over 90. Labetalol or extended release nifedipine are still the drugs of choice in these patients. In individuals with CKD, treatment should target an systolic blood pressure goal of less than 130 to decrease all-cause mortality, with ACE inhibitors and ARBs still preferred. Lastly, the guidelines comment on the role of technology in blood pressure monitoring and recommend use of validated devices with appropriate cuff size, emphasizing that cuffless devices such as smartwatches are not recommended for diagnosis or management. And that is all the time we have for today. In our next episode, I'll invite APHA member Ryan Waldschmidt to unpack how the updated guidelines are impacting his practice. Thanks so much for listening today, and please don't forget to visit the Learning Library at learn.pharmacist.com to earn CE credit for this month's podcast. Thanks so much and take care.